panel of people to speak to you. Professor Mark Hutchinson, you've just met, and he was speaking to you as well. Professor Paul Glare is joining us, and he has just joined us right here. He's the first person here to my left, your right. He's the Chair of Pain Medicine at the University of Sydney and the Director of the Pain Management Research Centre at the University of Sydney. Penny Tuffin is, this all worked out beautifully. It's exactly as I've got it listed here. Penny Tuffin is an advanced practice pharmacist, palliative care and pain management at the Royal Perth Hospital, Fiona Stanley Hospital. Next to her is Professor Melanie Lovell. She's the medical director with the Greenwich Palliative and Supportive Care Services, HammondCare, and director of the palliative care services at Mater Hospital. And of course, you know Tony Gill, because he was just speaking to you a moment ago. So this is about pain. We all feel it, but we can't see it. There are many new products to use to help manage and support pain. And as you heard today, there are some innovative ways of thinking about pain. So please welcome our panel. This is pretty interesting. I'm going to start off, I guess, with, and I guess it's an assertion of mine, or maybe felt in the room as well, and it comes from what Mark was saying before. Is there a philosophical, ideological divide here between the ways in which pain is approached and can be managed for a patient, and are the ideologies or philosophies sometimes irreconcilable? You're closest to me, Paul, so I'm starting with you.
Okay. Well, yeah, I would say there is an important divide.
You would say the divide was important?
Yes,
okay,
yeah.
Go on.
And I'm not entirely sure I would call it ideological or philosophical, but I think it's important to distinguish between pain, which is a subjective experience, versus the transmission of pain signals or nociception that Mark talked about such elegance. And I think that pain as a subjective experience is like other subjective experiences, like beauty or love or anger or whatever, and subjective experiences will cause people to think and act in different ways. And I guess it comes back to now we understand why trying to influence how people think and act about pain is important. But even before we knew that, it was known that pain can be impacted on other than by interfering with the transmission of the signals, but by trying to have people be more helpful in how they're thinking and acting with pain and less unhelpful. And I'd talk about that more later if I get the chance.
No, that would be great. Penny Tuffin, can I ask you to jump in on that?
I think in some respects it is necessary to understand they're totally different, but I would hope within a palliative care context that we actually use both modalities when we're treating patients for their pain. I think we generally are good communicators, and I think that's really important. I guess it's coming as a pharmacist, I think it's very hard for people to talk about their pain unless there is some physical relief in that pain. So I think we need to actually be using both ideas and modalities together.
And Melanie, do you think that I'll say we, I'm not part of your community, but I'm part of your conversation. Do you think that we do?
I thought Mark's talk was just brilliant, and it was fascinating to hear there was one word there that I thought could actually become the word of the conference, the connectome. Has anyone else ever heard connectome before? And what you talked about was the AMPs, and I think what we do in palliative care with our multidisciplinary teams is address AMPs. I always call it pain modulators, so the things or threshold issues, these are the things that we as a broad team address when we're looking at psychological distress, spiritual distress, and so on. I think, as Penny said, that we use both the pharmacological and all the other modalities, not just talk-based, but also spiritual, physical, and so on.
Mark, I just want you to expand a little bit more on that really fascinating talk that you just gave, particularly in relation to the new ways that perhaps those who are trying to provide pain relief to patients in a more practical way, what they might be. Can you describe that a little bit for us?
So I guess the challenge that we've had in the drug development space has been that we've always tried to create more potent and more specific drugs targeting very, very defined single entities, a receptor, an ion channel, or an enzyme. And many PhDs and many postdocs have spent many, many hours trying to refine these agents down to these single targets. And yet what we know is that pain and persistent pain and the emotional experience around that is not ever a single target, and there will never be a single medicine that is able to remove that persistent pain mechanistic underpinning. So that means there's a wealth of old drugs and what I would term dirty drugs, which hit multiple targets to intervene in the persistent pain problem. Now, from a drug perspective, from a pharmacy perspective, they're a nightmare because they have 101 side effects and 1,001 other off-target effects and drug interactions that you don't want. But they're able to work fairly effectively. Now, in the population out there, our patient population, there is the expectation that if the first drug doesn't work, then give me another drug that does. And if that drug doesn't work, then there's something wrong with me because you're not going to believe me because my drug doesn't work. And then there's this suggestion that you go and talk to someone about your pain, and then it's, well, you think that I'm not real, my pain isn't real. And I think the key point that I would say about the two sides of the fence, it's perhaps not on our side, the academic or clinical side, but it's on the community's side, that there's an assumption that if the drug doesn't work, the clinicians aren't going to believe me and therefore my pain isn't real. And I think that's where these developments in understanding drug diversity and drug dirtiness, and cannabinoids are a fascinating hot topic at the moment, but there are many other drugs out there. Ketamine is a great one, for example, which is as dirty as they come and has many, many actions. These old agents may in fact be the immediate potential for translation to provide a solution, but I think the talking and the other physical approaches are just as valid and just as mechanistically linked to pain.
I think we should try and get to that a little bit more and dig into that a bit further. But before we do, Tony, our topic today is contemporary pain management. As someone who works in the TGA, specifically in this field, what's your initial response to that? I mean, are there contemporary modes and interventions and modalities that perhaps we might be not aware of?
Unfortunately, it's not quite my area around it, but I think, there's always new drugs, but I think the problem is that the people are after, or the companies are after new drugs for which they can have a patent for. And the problem is actually getting research done on older drugs and then getting the indications which they're approved and maybe subsidised, then put through the system. Because I think that's where some of this comes in, is there's not a lot of incentive for people to do some of this research. And that's where it's been more investigator-led rather than company-led, which then gets very difficult to make a company who, for the intensive purposes, controls the entry we have to amend its indications.
Paul, Claire, what do you think of that?
I think that in the case of cannabis, I think it, it seems like it may or may not have some impact on the sensory side of pain, but I think it also has these other effects in terms of relaxation. And coming back to what I was saying previously, the International Association for the Study of Pain came up with a definition of pain many years ago, which is kind of cumbersome, but I think it's this kind of discussion which makes it clearer what they were trying to get at. They said it's an unpleasant sensory and emotional experience, and we're talking a lot about the sensory part of the experience. And while we've talked about the emotional part of it in terms of BABs, I guess, but the issue is that the emotional part of it, whether or not we understand why they're important, what it does is have consequences. So in the chronic non-cancer pain world, the kind of abnormal emotions that people with chronic pain have, they lose confidence to do things, they're frightened to do things, they catastrophize their pain, they feel unjust that the pain has happened to them, and these have very bad downstream consequences which can be dealt with directly. So if you could get people to stop thinking that they have to rest every time they're in pain and go to bed, and keep working through it. They don't get deconditioned, they don't take a lot of drugs and have all the side effects. And so I think while we know, like Mark said, you know, we know at a scientific level that it may help de-amplify things, but in the short term, getting people functioning better and doing things without taking a lot of drugs and having other things stuck into them is an alternative approach.
Yeah, well, I'd like to talk about that. Melanie, in your experience, have there been those approaches that have been more useful, particularly when you consider the case? And I could see you nodding where Paul was speaking about that place that patients can get into when they start to be overwhelmed by their pain, which sounds perfectly normal to me.
Yes, and that's often the point at which we meet people because they're referred to palliative care because they are overwhelmed by their pain, and particularly in association with a life-limiting illness, that's the ultimate in danger.
Yeah. And every signal of pain is signalling, the imminent end as well.
Exactly right. So they're very, very tightly associated. So that's where we do need all those modalities. So counselling and support, listening, and so on. And a little bit later, we're going to talk about the Australian Cancer Pain Guideline, and really top of the list is comprehensive assessment, where you actually get to the bottom of all the things that are really concerning people.
Yeah. Why is there this, and this is not as a pothead speaking, the last time I had anything to do with cannabis was at second year university, and yes, I inhaled. As Barack Obama said, wasn't that the point? Why is there this neurosis about cannabis? I mean, when we have stuffed ourselves full of the most extraordinarily potent opioids, as you said, Mark, I think for thousands of years, why does cannabis pose this extraordinary caution and care when it comes to drug use? Tony?
I think one of the issues, and I sort of alluded to it when I was talking, is there really hasn't been good research over the years. Part of it was because it's been...
Oh, you haven't been speaking to the right university students.
End of one study.
Yeah, I'm not sure their pains they were treating. But I think the issue there is, and there haven't been the trials to the level of evidence, because all our doctors, we train well now to be evidence-based, high levels of evidence to do things. But the evidence that existed in the trials that is there is actually much lower evidence. There's a lot of anecdotal information. And even where people have been doing reviews of all the different trials, there isn't getting a lot of strong evidence around a lot of the pain.
Right.
And when people have actually gone and looked at, because also it depends on what the method of the trials were and all those to how well things were controlled. So I think there's certainly bits of information, but it's certainly not as strong. And certainly one of the things that we're involved with the states and territories and the National Drug and Alcohol Research Centre and specialists is looking at a whole lot of guidance documents based on what's the available evidence to provide doctors and patients with what actually is out there to help decision making.
Does anyone have a response to that?
Yeah. I think part of the problem too, Virginia, is that there's a few things. One, there's a whole lot of drugs we've got now that we prescribe quite readily that if they were coming onto the market today, they'd never get approved.
Yeah.
That's one point.
Yeah.
The other is that when university students were smoking cannabis, they had fit, well, young bodies. We're talking about older bodies that are diseased, that are going to handle drugs very, very differently.
Yeah.
So we're actually talking about two very different things.
Isn't it also that this was community-led rather than drug company-led? If this is drug company-led, you'd have tons of research. But this is actually community-led by people who said, I gave my mother a joint, it seemed to relieve her pain in her final days of cancer, put the damn thing on the market. Isn't that pretty much how it sort of happened?
Yeah, and the drug companies are now getting...
Oh, I'm sure they are.
And one of the products that Tony mentioned is Sativex, so that is on the PBS for a different indication, and the paper's just come out on that, looking at it versus placebo.
Yes.
In people with advanced cancer and pain despite optimised opioid therapy. And two studies by Mary Fallon, and both of them are negative, so that cannabis isn't better than placebo.
Right. Look, you introduced the placebo discussion and I'm fascinated by that. I mean, because that intersects, doesn't it, with, brain training and the like, and the concept of neuroplasticity. We know, and we've all read, and I've been enthralled by, research papers around the placebo effect. So how does that fit in for our people here today in a contemporary, practical, pain management sense, Mark? Where does the placebo effect fit in?
So for palliative care, placebo probably won't touch the sides, simply because the degree of nociception that is occurring in terminal cases is extraordinary, and therefore very little of the mechanisms underpinning placebo will overcome the pain. Now, it's worth between sort of 5 to 20 milligrams of morphine, depending on which study you look at, but it's a significant contributor. The amazing part, though, is that if you can harness it, then why not do it? Now, if you can harness it well without causing any harm, and I would argue cannabis is a very dirty way to do placebo, there are many other ways. White coat works. Blue pills are better than red pills. There are many, many other ways to elicit a placebo response. And there are situations where some medicines will actually work better when there is a placebo engaged. How we do that in a standardised way within the population, we don't have that yet.
Yep.
But is there something we can actually train in individuals to be able to create a better placebo? Let's give it a go. Now, as the science underpinning it gets better, we'll be able to do that.
Paul, jump in.
I agree with Mark. And Damien Finnis is a colleague of mine at PMRI, and he's a world expert on the placebo effect. I think the important difference is that the concept of the placebo effect, which has been described as a whole ritual of healthcare, and I think it's very strong in palliative care, and it's probably strongest in palliative care. And I think that's probably why a lot of the PACS studies have come out negative, that it can be so strong that it can trump the effect of a drug like ketamine. And Damien's done research where people are having a morphine infusion, and some of the patients see it there with morphine written on it. Other patients have the same drip running hidden behind a curtain, and the pain relief that they get is much lower with the hidden morphine when it's exactly the same. And so the drug itself, the person itself can have that effect, but then the whole ritual of caring for a person amps that up. And I think having worked in palliative care and tried to do clinical trials, to get a sick patient onto a study, they get the most Rolls-Royce treatment, and I think it just, I think I've forgotten what the placebo arm in the ketamine study was, but it was massive, right?
Yeah, it was huge.
Yeah, 3.
57% of people on placebo.
So you're right off mic, so say that, but just, that's okay.
I don't recall the exact number, but
No, as you talk, I'm going to move this here so you're more centre and then we can really hear you. There you go, that's fine.
Yeah, many of the patients who got the dummy ketamine got a good response, and the people who got the active drug got all the side effects, and so it looked very bad. But really, it was a testament to the clinical trial team and the doctors and the nurses looking after the patients and keeping them on the study, which really improved their pain, which comes back to the whole emotional part of it is just as important as the sensory part of it.
Sure. One aspect of that, I guess, or a fundamental aspect of it is fooling the patient. And well, it is. And I know you won't like that, but tough. And we're talking here about a patient-centred approach, and one where the patient has a great deal of agency over what they do. So if we pull out then, if we still want to take a similar approach, but we pull out the idea of, fool me once, then instead I guess we're talking, aren't we, about some sort of cognitive behavioural therapy as part of your talking approach to pain management. Can anyone illuminate that for me who might have some experience of that? Yeah, go ahead.
So I think what we're talking about there is trust. That's the essence of it. And if someone has confidence in their team, then they will have improved pain outcomes. And we see it, I would imagine most of us would see it regularly, that being able to engage with someone who really wants to understand the person, really understand what matters to them, has knowledge and expertise that they can bring to that situation. Pain scores will often come down. That's the placebo effect. That's not fooling, that's real.
Yep.
I think it goes further than that too. I think it's the way that you introduce drugs as well to a patient. If you've already got the trust, You've already talked to them that there are different options. I'm going to try this and I think it will work for you.
Yep.
I don't think that's fooling them. I think that's having an open disclosure and saying that this is what I think with my expertise is going to be the best option for you. I don't see that as fooling. And I think that's different. Sorry, Paul.
Yeah,
I think
no,
that's
go on.
different to somebody just rushing into the room and just writing something up, leaving the chart at the end of the bed and going. And we see that so frequently.
Yeah, I'm sure.
I mean, I can just briefly explain about 2 studies done recently in chronic pain looking at the placebo effect. One study done in people with back pain in pain clinics in Portugal were having physiotherapy and anti-inflammatories, and they were randomised to continue that or to be given a placebo. And they were told, this is a placebo, and they had a 15-minute lecture on the placebo effect, and that this pill has no chemical activity whatsoever.
Right.
Those people still got better pain relief. So it's not about fooling patients. And another similar study done with placebo pills, like anti-inflammatory, and then with or without atropine to dry your mouth out. The people who got placebo by itself had the least benefit. People who got the anti-inflammatory by itself got more benefit. People who got the anti-inflammatory plus atropine, so they experienced this dry mouth and some side effects, actually did the best of all. And people who got atropine and placebo did better than the people who just got the anti-inflammatory. So it's not only thinking that they're going to get something good, but experiencing something bad kind of makes it like more potent as well.
Oh, we're entering strange territory. Mark.
I think we're thinking here also about the good aspects of placebo, but of course you can actually induce the aversive side as well, which heighten the pain state.
Right.
And so if you yell at someone, you create a state of lack of trust. You can actually create active systems which will drive anxiety and heightened pain states.
Yeah.
And so whilst I think we don't want to be tricking people, all of these placebo effects are conditioned over a lifespan, and we have learnt that if people are treating us nicely, then our bodies are doing a good thing here, so our system becomes responding with an analgesic response.
I want to try and get the room involved. I'm sure you must have a ton of questions. Please don't be shy and please don't hesitate. This is a rare opportunity to bounce some ideas or questions off this marvellous panel. I've got some mics in the room, don't I? Can I see where my roving microphones are? There's one here and there'll be another one. Give me a hand, anyone, or I'll pull you at random out of the audience. Anyone who's got here, we've got one here. Good on you, Sue. And then after Sue, I want to hear from, come on, do I have a hand up there? Yes. Okay, so the microphone then is going to this gentleman right up against the wall in black at the back. Go, Sue.
I'm just wondering, it's slightly left field of what you're saying, but with the research and knowledge and hypothesising that's coming through on the importance of the gut and the microbiome to our immune system, to our brain, people talking about part of our brains and our gut, different ways of expressing and conceptualising that. I'm wondering about what access do we have to moderating pain responses, immune responses, all of that through modifying gut flora, digestion and so forth.
Thanks, Sue. That's another brand new frontier. Who'd like to jump in there, Mark?
So I can speak to some of that evolving field. Very little yet has been done in the pain space. Most of it's been done in the spectrum disorders, which do have very good grounding in the neuroimmune effect. We don't yet really, we can't even culture most of our gut microbiome. So we don't know 90% of what's actually there. So we have very, very little information really to go on to be able to create the good bits. Fecal
What would you
transfers,
hypothesise?
well, fecal transfers do work. Gut helminths are working.
What are
So
gut?
helminths are worms.
Right,
So you can intentionally infect someone with a worm, and that does have a beneficial effect. There is
You're going to
some.
talk about leeches next.
No, I haven't got anything on leeches, but this gut-to-brain axis is real.
Yeah.
We don't know how to target it yet, and it's a chicken and egg scenario in persistent pain. Is it that your gut microbiome has gone bad first, that then triggers your persistence of your pain, or is it that your pain acutely has then changed your gut microbiome, which then flips you around? We don't know yet. All I know is that there's a lot of future of our culture getting used to eating poo.
Not eating it.
Well,
consuming
it in a clinicalised. The pharmacists will be formulating.
You'll never want to go to the chemist. Paul, anything you'd like to say?
I mean, at the World Pain Congress a year ago in Yokohama, they had a whole plenary session on this. The world experts, a guy from Dublin, and I mean, I think like with the meninges and the lymphatics, they're saying that it's via the vagus nerve,
right,
taking messages from the gut to the brain and through the autonomic nervous system, so that there is now this passage that's identified. But yeah, the next thing is what are the kind of targets there.
Okay. Yeah. Did we get the microphone over here for a question? We can't hear you. Just trying to turn
Is that better?
There
Yes.
you go.
Stephen Ginsburg, I'm a GP, and to add to Melanie's comment, the Old English origin of the word care is grieving with. So in a palliative care setting, obviously that has a strong palliative effect, to grieve with someone and their family. So it's a comment, not a question.
Absolutely, yes. And I'm sure that connection is, enormously helpful too. Oh dear, our polling question is, would you consider a fecal transplant? Oh, come on, you came up with that. Well, and there's the yeses and there's the no's. It depends on the condition you have. Don't have a fecal transplant if you don't need to have one. And that all depends.
Have a brain transplant?
I want to talk about anxiety and pain. And I think this might be an interesting one to kick around, the relationship between the two as we understand it and what might be useful for our carers in the room. Penny, do you want to kick off on that?
There's a huge component of anxiety associated with pain, particularly if you have a life-threatening disease. And I think, we often see patients who their pain is completely out of control, but it is more about talking to them. It's more about finding out what's driving that pain, because a lot of it can be anxiety driven, about not knowing what's going to happen to them next. I don't think giving them a medication for anxiety is actually what is going to be the most useful in that setting.
But do you believe it's a link that perhaps is not as well understood by those who hope to care and provide pain relief?
Yeah, I guess so. It's a pretty big call. When you work in palliative care, I would hope that most people do understand the link, and so working in that space. I also work in acute pain, and so I see that in the acute pain setting, particularly people who've had massive trauma and they don't know, their whole life has been turned upside down and they don't know what they're going to be facing. And I think, in a lot of units, people are very good at recognising that, but certainly across healthcare, there's pockets that are not good at recognising that. I certainly don't think patients recognise that.
Yeah.
Patients don't recognise that their anxiety is what is causing their pain. And I think it's a community thing that needs to change rather than a professional thing, a bit like you were saying before, Mark.
Melanie, what do you think?
Well, I think for people who have pain, who don't really understand it, it's very, very frightening. And the process of explaining what's going on can make a huge difference, and giving people a sense of control, because when people are in pain, they can feel really out of control, and explaining to people, how to manage it, giving them self-management strategies, giving them education about the cause and also the treatments, empowering them to be involved in their own pain management.
So tell me about the work that you're doing in the cancer pain space. Explain to us a little bit more about that and whether it's transferable, I guess, to other fields and areas of dealing with pain.
So the main part, apart from being a clinician, is development of a guideline, a National Cancer Pain Guideline. I can see it's come up on the screen there, and as you can see, we've developed that on the basis of Meads and Bowers' person-centred care theory. So our first set of recommendations is about person-centred care. Those principles, what we've done is looked at international guidelines. We've adapted the recommendations to the Australian context. We then sent that out for feedback, and many of the audience will have fed back on those guidelines. It's on a wiki platform, so it's readily updatable as evidence comes to hand. So the whole way of developing guidelines is certainly applicable in other areas as well. The second part of the work is, as we all know, guidelines can be developed and they just sit there, particularly complex guidelines that include all the psychosocial as well as the pharmacological, non-pharmacological. So we're now working with cancer centres around the country to implement those guidelines in practice. It's essentially a robust evaluation of a quality improvement program for those cancer centres, and we're using strategies such as audit and feedback loop, patient self-management strategies, again looking at pain management plans and goal setting for patients. And the third strategy is spaced education, which is an email-delivered education program. We're using a QStream platform, and we're evaluating the outcomes so that those cancer centres can know how they're doing in terms of adherence to the guidelines and pain outcomes.
And what's been the best improvement in your clinical experience, your practical experience? What's been the best most recent improvement for pain management?
I think the increasing awareness of the non-pharmacological elements. Such as exercise, counselling, distraction. There was a beautiful picture in, I think, Kirsty's talk in music where people who are distracted from pain really have a reduced pain experience, and that's a physiological thing. Yeah. So while there's a really important role in pain management for lots of pharmacological strategies, and I think a really important step is that we are now getting more and more robust clinical trials that are showing what works and what doesn't. Yeah. So I think understanding that we need to put what we do know works into practice better and do it well, I think these are the major advances.
Paul, what's been the best advance for you in recent times in pain management?
Well, I think in that kind of area, and what I would throw into the discussion about pain and anxiety is that I think there's two issues. One, this whole issue of whether people with cancer have anxiety because... So what is it that's making... And people who have cancer and pain and are anxious, what are they really anxious about? Are they anxious about the cancer and that the pain is a manifestation of the cancer, or are they anxious about the pain itself? Because there's data coming out of EPOC, which is the chronic pain version of PCOC, which indicates that people with cancer seen in pain clinics have the same anxiety about pain as people with chronic back pain and fibromyalgia and those kind of things. So this whole thing about cancer being, pain being the most severe consequence of cancer has actually got very little basis in fact. I mean, it may be true, but it's not really proven. It's actually based on a telephone survey of people in Wisconsin in 1986. And it's not actually, and it's quoted everywhere, but when you try and see where does it come from, it comes from a telephone survey of people in the American state of Wisconsin. And I think that needs a fresh look at. The other thing is, I think, whether or not it's true, I think that was the case in the 1980s when palliative care really took off and opioids took off, when people were dying. But cancer's a very different illness now. And a survey done in oncology patients and I know it's palliative care and not just talking about cancer, but a survey of oncology patients last year showed that a quarter of them who've got pain, it's got nothing to do with their cancer, it's their chronic back pain. There are a lot of people who are diagnosed, because of screening, they're diagnosed with early stage cancer, they have an operation, some adjuvant chemotherapy, but they've got a bad back or they've got a bad neck or whatever. And this whole thing that because you've got a cancer diagnosis and you've got pain, it's because you're frightened of dying, I think, there's definitely, that's the case for someone who's, terminally ill and in palliative care, but for a lot of people with cancer, just because they've got pain doesn't mean they're anxious because they're frightened of dying. And I think there are specific strategies for helping people deal with anxiety from pain rather than anxiety from cancer per se.
And so, and just on that point of the most interesting and useful recent development in pain management, in your experience, what might that be?
Oh, well, you know, yeah, that's a very broad question. I mean, you know, the
You
drugs...
can make it as specific as you like.
Well, I think, you know, I think on the biomedical and the interventional side, I think things like spinal cord stimulators have a role for symptom management, but with the current technology, they're not MRI compatible. So for palliative care patients who are going to need MRIs, like again, cancer patients, that's tricky at the moment, but they used to be just used for pain in the legs after back surgery. Now they're being used for angina, for chronic abdominal pain, for migraine, all that kind of thing. Right. So I think there's stuff going to be happening there. There was a paper in New England Journal of Medicine about what the NIH's response to the opioid crisis in America is, and they're talking about gene therapy and deep brain stimulation. They didn't talk about these non-pharmacological approaches like CBT, and not only it was an omission because of there's actually data there, but Mark's actually shown a reason why it's so important as well to be doing that. And it's not just kind of complementary therapy and making people feel better, it's actually reversing the changes in their brain and their spinal cord that are causing all the problem.
I'd like to ask you the same question, Penny, about the frontier, if you like. But before I do, any hands that I need to see? Any questions that are coming? Yeah, a question here, and then Penny, I'll come to you for that one, if that's okay. Get your hand up again, just so we can bring the microphone quickly to you. Might need to pass that down the line in order to get it to him. Thanks so much. Here we go. Thank you. Nice and high.
Okay, beautiful.
Hiya.
There was an article in the last 12 months suggesting that the worst thing that ever happened was that the World Health Organisation's analgesic ladder of looking at opioids in cancer pain was transferred across to more general chronic pain. Would you care to discuss?
Would anyone like a Mark?
So, yes, I think I wouldn't blame the World Health Organization. I think there was some very, very good marketing done by a company who saw an opportunity to get opioids in the hands of people who didn't need opioids, and with in the US, a health system which rewarded prescribing to fix a problem. And why not fix a small problem with a sledgehammer? And I think that's actually what's transpired. Where we are now, so I was meeting with Nora Valco, the director of the National Institute on Drug Addiction, who had been instructed by Francis Collins, the director of the NIH, who had been yelled at by Trump to fix the opioid problem. They are about to spend about $330 million to fix the problem. Now, what was exciting was in that meeting, they are actually talking about training, and they're talking about introducing non-pharmacological interventions. The opioid crisis has, I hope, we've passed the first part in the developed world. Where the biggest problem we have now is in the developing world, with the same companies now marketing to the developing world the same practices we know are wrong, and yet they're marketing those now. That is the challenge we have, that we have to stop. And that is completely inappropriate, given we now know from the IASP down that the use of opioids in the way it had been for sprained ankles is completely inappropriate.
Thank you. Any other questions? Another hand that I can see anywhere? Or I'll come to Penny. And so your experience then?
I think if I was asked the one thing that's made a big difference, I think in a lot of respects it has been the opioid crisis. It's actually made lay people realise that these drugs aren't safe. It started conversation. It's actually made pain management a sexy thing to specialise in now. Like it never was, whereas now everyone wants to know about pain management. So in a roundabout way, and I am an optimistic person, I hope that in fact this will actually do some good in the long run, that people will have to start talking about not just reaching for a pill. We know already those conversations are happening across health with bacterial infections versus viral infections. So maybe this is our pain changing community mentality about medications and starting to realise that in fact other things work much better.
Tony, can I ask you the same question? In your experience at the TGA, is there some new frontier?
I don't know whether there's really, it's probably not an area where there is a lot of new drugs coming along. I think there's all the old drugs, and I suppose some of the times issues come up with the older drugs, to how effective they are as well. because as was alluded to, a lot of these were approved 10, 20, 30, 40 years ago. And I think people are now starting to have more information and understand some of the constraints around them and when things should be available and how they should be used. But in the end, I think with all the current drugs, it's really the prescribers and the information to prescribers is the important thing.
I was struck by Penny's observation before about if some of those older drugs tried to come onto the market now, they'd absolutely never get approval. Do you agree with that?
I mean, there's certainly some if they came on now. The problem is they're there and they've always been used then as comparators for the newer drugs.
Yes.
To say this one's better than what was there. But and a lot of them still have uses, but whether it's broadly useful in some cases.
Yeah.
And I think it's a difficult one to go back and say, well, no, it shouldn't exist at all and constrain it. Because again, a lot of these now don't have patents, they don't have any of those controls, so some of the other incentives. But it's more around how you can affect prescribers, I think, rather than those.
Mark, what are you aware of in terms of development and practice coming from the kind of research that you're doing now, where it's being practically applied?
So the greatest challenge and opportunity is the ability to objectively quantify pain. So the opportunity already exists today to take a brain scan and actually determine whether the person is in pain, and there is now new data suggesting you can actually quantitate how much pain that person is feeling from a brain scan. Now that begs the question, could we end up one day with a blood test for pain? And my research centre is actually doing that research to see if we can have a blood test for pain. Now that's exciting if you've got a population who aren't able to communicate, who are unconscious or dementing, and you want to be able to know, are they in pain? But the medical legal huge thing is, what happens if the blood test says no and the person says yes? What do you do? And I don't have the answer to that, but these are questions that the IASP is tackling right now, so that we are in a position so that we don't end up getting summons to court to provide counsel or opinion on cases where people are claiming that they have pain and blood test or brain scan says no. The opportunities are huge. It means we can actually identify people who aren't able to communicate or aren't speaking our language or we don't trust what they're saying because they're dementing, whether they have pain or not. But it also has this potential downside as well.
Did you want to jump in there and say something, Paul?
Oh, I know. I mean, in fact, Australian Pain Society meeting this year was in this very facility, and this exact discussion was had upstairs there. And this is where your original comment about, ideological or philosophical still comes back to, if someone's in love, sights will light up in their brain, but will a divorce lawyer say, well, you're really not in love because it's not lighting up? And it's exactly the same. What are you really measuring in those scans? Is it actually pain or love, or is it the neurological activity that accompanies that subjective sensation? That's really a question for philosophers.
Well, that's right, yes.
Theorists and
that's what I was struck with when you mentioned that definition before, a definition of pain as an uncomfortable sensory state, and I thought, well, that's work. It describes the hours between 9 and 5, doesn't it? So, yes, you're right. We'll hand that over to the philosophers. No, I love my job. What am I saying? We've got a live poll, which we can chuck out to you now. Have you experienced difficulty in accessing medicines for pain during the after hours period? There you go. Yes. Yes, quite, I think. Yes, but, or no. And there's your yes answer. Penny, do you want to jump in there? I know these stories from people who... I can tell you a story of a dear friend of mine whose mother died in, the usual banal but phenomenal pain of cancer, and a friend of hers, and I think the script was written in Sydney and then faxed to Melbourne. Someone filled it in Richmond and then ran it across town to Docklands where it was administered. And yeah, I know, but I hear those stories are not that uncommon. Penny?
It shouldn't happen, because good palliative care is preemptively looking at what's going to happen next and having the scripts already written and the medication in the home. And that's only one part of that whole access anyway, is actually being able to find an all-night pharmacy or get into an ED. The other huge part that exists is patients in residential care, so aged care. After the hours of 5, they often don't have staff who can actually administer medication on a PRN basis. And that's a huge thing across a lot of our care facilities. And also if the patient's in home and needs an injection.
We're right up against the time, but just to finish, I just want to ask all of you, I guess it's a quick pop quiz. If you were in chronic pain, given what you know, what would you want as a treatment? Tony? Go on, tell us you'd want it.
I think it'd be. It's a bit of everything. It's to some extent. It's that whole exercise and advice around how to manage, I suppose what I'd say, your perception of your pain or other things, as well as an appropriate pharmacological one, if there is one for that type of pain, because there are obviously different types of pain.
Melanie?
Evidence-based multidisciplinary team management.
Well done. What can you say? I want the buffet, I want my dog, and I want the champagne.
I find champagne is a wonderful pain management. Mark?
There's a couple of absolutely yes to receiving it from a qualified team of professionals. Absolutely an opioid, whilst I demonise opioids usually, but if I'm at the end of life, I would love my opioids. Some ketamine and some good old tricyclic antidepressants. And
don't give me this nonsense about there not being some ideological divide. This part of the room clapped for that answer. That part of the room clapped for that answer. Paul?
It's hard to add to the list. I guess a joint and a couple of beers would be add on.
I was so hoping someone would say that. And if you like, at the end of the conference, I'll give you my recipe for my cocktail, which I call the Friday Night Fog. And when the fog descends, all pain disappears. Would you please thank our wonderful panel this afternoon? Thanks for your attendance. What a fantastic opening day. You are free to go. We will see you here at 9 a.m. tomorrow morning. Have a great night. Enjoy Adelaide. Thanks, guys. Thanks. Marvellous. Thank you, Fiona.